But for those who've met me, my name's Hoong. For people who wonder what I do, in summary, I've taken over from Helen at Great Ormond Street. That's probably the easiest, shortest thing to say. And I'm going to talk a bit about this mysterious MDT that Claire and Neve kind of referred to earlier. And you can see that we're not, the title is deliberately, we deliberately call ourselves an advisory group because we're not technically an MDT in the sense that what we make the recommendations that come out of this meeting are not binding in the sense it sounds very much semantics because in essence, as you see, the advice we provide, a lot of the professionals who come to this meeting find it really useful and actually is used within their clinical practice. You've seen quite a lot of this already today, so we know that childhood brain tumors are rare, but actually hypothalamo-pituitary tumors are even rarer, and you saw a statistic earlier saying that it's about 2% of children's and young adult brain tumors. And this is just a reminder that this is the incidence of cancer by age distribution, and that you can see this is all brain tumors, basically. And you can see that in childhood it is much rarer than adults. But one of the things that maybe hasn't been made clear today is that when we look at cancer statistics, in brain tumors, low-grade tumors count in those statistics, whereas in things like breast cancer and ovarian cancer, it needs to be a malignant high-grade tumor to be part of these statistics. And that's kind of relating to what you can see today in terms of the impact of brain tumors on overall function. So this is just some pie charts to show you how rare pituitary tumors are versus kind of the overall distribution of all the other brain tumors you can get. This is just a case in point. So this is a patient who is now an adult, who actually was an international patient who came to GOSH. He presented with a very rare pituitary tumor called prolactinoma at the age of 11 years old. You can see a bit like some of the other pictures you saw earlier. It was one of those tumors that grew and then progressed despite treatment. It was very resistant to the standard medical treatment, and he landed up having surgery and radiotherapy, both at GOSH and at the Children's Hospital of Philadelphia, and he was left with multiple comorbidities. So really, why is this group important? So this is unpublished data, actually. It was a survey sent out by the team in Liverpool, sent out to neurosurgeons across the world, where they presented 10 cases, essentially 10 MRIs, asking these neurosurgeons what they would do, what was their next step, with a bit of a clinical history. And you can see it was a bit of a luck of the draw thing. Every surgeon would do things slightly differently. And therefore, it's really important that we have kind of experience in terms of the centers who operate, because at the moment, every patient, it depends on which center you get seen, really, and what you get done. There isn't a standard of care. So there are strengths of national MDTs. For those of you who've got other tumors, you might be aware that there are national MDTs for various other brain tumors. Most of these actually come out of the results of kind of chemotherapy type trials. So for example, ependymoma, there is a national board for that, and that really was born out of an ependymoma trial, and it is still running. So even though patients might not be on the study, they are also discussed at this board. But there aren't really any MDTs apart from the one I'm about to talk about from a hypothalamo-pituitary tumor point of view. There are several papers talking about the benefits of having such MDTs with regards to kind of treatment outcomes, but also increasingly patients and parents are quite keen on being discussed at these MDTs and also being part of these MDTs. This is actually prior to the more recent NHS England cancer plan. So there was a previous set of requirements from children's cancer principal treatment centres, and it talked about what these centres should actually have access to. So you've seen some of the things in the previous presentation, but quite similarly, it was about having multidisciplinary meetings, particularly looking at long-term neurorehabilitation, including late effects. It also required close working between all the disciplines involved, but very interestingly, endocrinology was not on that list, as you saw in the other presentation. And then there was actually mention about regional working with reference to kind of national clinical advisory panels, which, as I say, don't exist for this particular group of tumors. Helen's mentioned some of these guidelines that have been published over the years. So I had the privilege of kind of being involved with the craniopharyngioma guidelines, but Marta over here was involved with the pituitary adenoma guidelines, and then Manuel over there led on the pituitary stalk thickening guidelines. So these are all guidelines that really were driven by Helen. We talk about a 3-line whip in politics. She drew a 4-line whip, I think, on us. And it, the only reason it really got completed over the course of a decade was really, I think, because you drove us very hard. And all these guidelines cover all those aspects of clinical care for these tumors. But more importantly, the guidelines actually highlighted something called centralization, which very interestingly sounds very, for patients and families, it sounds very intuitive. Yes, of course, cases should be centralized in centers of expertise. But actually, when it came to publishing the guidelines, there was a lot of resistance around centralization because it required a lot of restructuring of what already exists. Obviously, surgeons are performing surgery in lots of different centers around the UK. And therefore, there is a resistance to try and conglomerate teams within certain centres because it does require quite a significant amount of restructuring. I'm going to talk a bit about this group that currently runs out of Great Ormond Street. So we meet once a month. We meet virtually, and it used to be kind of a hybrid meeting, but actually since COVID, it's become entirely virtual, which I think has really helped because more people are able to attend. There's roughly, well, I'll tell you about the history a bit more, then I'll get to what it's doing now. So it really was started off between 3 centres, so London, Manchester and Liverpool, so the big neurosurgical centres. And the idea of a national virtual MDT was first put forward then, and initially the focus was on craniopharyngiomas particularly. And there was a proposal made to what was known as the National Commissioning Group to actually basically fund this meeting and also talk about centralization of care. And there was an initial meeting in 2011, a pilot meeting, where only 8 cases were discussed over the course of 4 meetings, and there was a proposal for pump priming of this meeting. This then moves on to monthly meetings, but unfortunately the commissioning group actually declined funding because they described this group as more of an interest group rather than an MDT. And the advice we were given was basically to discuss these cases with your local adult pituitary service because there was no recognition of the need for a similar pituitary service within the pediatric setting. But also in 2013, that was the beginning of the guidelines that I showed you on the previous slide. And essentially where we are now, as I say, we meet monthly. The meeting used to be for an hour. We now do an hour and a half, and we have the opportunity to discuss about 6 cases within that time frame. That, as I say, it's time limited, so there's only an hour and a half of time to discuss very complex cases. We've discussed several times about increasing the frequency of these meetings, but unfortunately there isn't enough time in people's job plans, so consultants don't have enough paid time to come. And actually, I'm probably one of the few consultants, because I lead this meeting, that's actually paid in terms of time to run it. A lot of my colleagues come out of their own free time. It's run over lunch quite deliberately so people can come. And therefore, it's still very much, it fluctuates in terms of month on month who comes. But generally speaking, we have now, I'd probably say about 30 people who come every time. So we've got a good group of people. Bryan, one of our previous residents, will show you some data, but the number of cases we discuss is increasing. And we're also getting more international recognition as well. So I'm actually going to ask Bryan, who's one of our previous resident doctors who used to work with me at Great Ormond Street, who's now doing his PhD. He has done an analysis of all our outcome data from this meeting, which I think Helen asked me to do many years ago. I never did, and I finally got someone else to do it. So I'll let him present that data. Come on, Bryan.
Right here. So, as Dr. Gant just described, this MDT has continued to provide guidance for clinicians across the country since its conception 15 years ago. So this led us to reflect on the sheer volume of work that's been undertaken since then. So, between 2011 and 2024, 149 meetings have taken place, with over 550 cases of complex hypothalamic pituitary axis lesions having been discussed. Looking at the bar chart, you can see that the number of new cases in blue has continued to rise in more recent years. Between 2020 and 2024, we had over 220 cases discussed, with the vast majority being consistently new referrals. Looking at the breakdown of tumour types, you can see in brown and red that pituitary adenomas remain the most commonly referred lesion to our centres. Furthermore, craniopharyngiomas fall just shortly behind in terms of numbers. It's interesting to note that we require an ongoing collaborative approach. So, for instance, in a 5-year cycle, we might have just one case of a TSH secreting adenoma, which can make care quite challenging for clinicians. More recently, we've noticed a changing landscape in terms of what tumour types we get referred. So, if you look at the numbers of undifferentiated other lesions, nearly 20% of cases don't fall neatly into a diagnostic category. This can make things incredibly challenging. In terms of the clinical queries that get referred to this MDT at the moment, it falls into one of 3 broad domains. What's the diagnosis? What additional tests as a clinician should I be ordering for my patients? And most commonly, how do I look after this child or young person in the years to come? In terms of clinical queries, we're really blessed that with our neuroradiology colleagues, we'd be lost without them. Furthermore, we have an adult endocrinologist who attends regularly. Our adult endocrinology colleagues, due to their demographic experience, have far more experience in managing these cases than we often do. We far less get commonly asked, what additional tests should I be ordering? But far more commonly get asked, how do I manage these risks in the years to come for children and young people? The most commonly referred management question we get asked is MRI surveillance. And how often should I be doing MRI scans in the years to come? This is a really data-heavy slide, but I just want you to focus on the purple bars. So this is the percentage of cases referred to the MDT, which leaves with a clear MRI surveillance plan, whether we should do MRI 6 monthly in 2 years' time, or we can stop safely. The more challenging domains focus around when should we perform a biopsy, or how often when we should commence radiotherapy, including proton beam therapy. As Dr. Gann described, this is a voluntary MDT, and this raises important questions around capacity and how far and how appropriate it is for us to continue to provide guidance and advice. So we've been blessed to have 16 of the 18 main paediatric neuro-oncology and neurosurgical centres across the United Kingdom participate in this MDT forum. Since 2015, about a third of our cases now originate from outside the original primary sites of London, Liverpool and Manchester. I just generated a heat map of a random year, and you can see that in red, London remains the most common site. However, we get cases from Belfast, Birmingham, Sheffield, and the list goes on. The reality is we want more and more cases from these sites because we know they're dealing with the same levels of complexity that we are on a daily basis. The issue, once again, is time and space to take these referrals. This doesn't even mention international collaboration. So back in 2015, we had our first referral from Wilhelmina Children's Hospital in the Netherlands. Since then, we've continued to accept referrals from Argentina to Hong Kong. And this raises 2 really pertinent ideas. Firstly, that there is a demand on the worldwide stage for a platform to discuss and elevate the standard of care to world-class standards. Furthermore, there's also a demand in other countries for what we're starting to provide here, a national HPAT advisory group. So, there we go. So, these are our final thoughts. There is a real need for a national hypothalamic pituitary access pituitary tumour board, in essence. We're seeing increasing numbers of referrals year on year, and there's a real need for clinicians locally who are making decisions around MRI surveillance, when to take a biopsy, to have significant levels of support. Likewise, we're seeing internationally a recognition of HPAT group as something that can really drive care forwards. Likewise, a registry where we record our HPAT cases will allow us to compare our care against these painstakingly crafted guidelines. And ultimately, we want to provide care which is exemplary. So about 20 years ago, our neurosurgical colleagues went through a period of change and reform where they centralised their decision-making but continued to provide care locally. To quote the report, they wanted to provide care which was safe, sustainable and world-class, not just ordinary, okay or good enough. That goal holds today. Thank you for listening.